Very good morning to all of you. I'm Arosha Disanayake, President, Ceylon College of Physicians. Welcome you this morning for the specialty update on pulmonology. Now, as you all are aware, the College of Physicians has a theme month, and every month we cover a particular specialty area of interest, and we have covered nephrology, cardiology, etc. And for the month of May, it is pulmonology or respiratory medicine. Already we have had the cutting edge series lecture where we listened to an expert on recent advances in asthma. If any of you missed that lecture, that was a fantastic lecture. That is available on YouTube in the CCB YouTube channel. Please, you may listen to that. And then today we have the pulmonology specialty update, which will be conducted by 4 eminent pulmonologists in Sri Lanka. We are very privileged to have speakers of such academic eminence joining us this morning for the benefit of all of us in the CCP, both consultant as well as specialist trainee community. Then, of course, the third item, which will be coming up very soon, will be the CCP pulmonology quiz, which will go up shortly. We'll give you adequate notice where you get a few hours to respond. And then, of course, you get attractive prizes for answering correct. And most of those questions will be based on this program, which is the specialty update. And I'm very grateful to Dr. Ravini, the president of the College of Pulmonologists, for helping us arrange this meeting. And then to start off proceedings, it is my great pleasure and privilege to invite Dr. Amila Ratnapal, who is the consultant pulmonologist from National Hospital in Kandy. And he will speak to us on tackling a crackling lung. Now, how this will go is for 25 minutes, Amila will speak to us, and he will reserve 5 minutes for questions and answers. If any of you wish to, if you have any questions, please type into the chat box. Dr. Riaz, the pulmonologist from the CCP, will be coordinating this program. So he will direct the questions to Dr. Amila, and then we can have a discussion. And then Dr. Riaz is there to coordinate all questions and answers. Right, over to Amila. Amila, I'm honored to invite you to speak to us this morning. Thank you. Over to you.
Thank you very much for your kind introduction. And first of all, I'd like to appreciate the Ceylon College of Physicians as well as the Sri Lanka College of Pulmonologists for their kind invitation to discuss about interstitial lung disease with you all. So today I'm kind to discuss about the crackling lung. Basically, my talk will be on interstitial lung disease, but I'd like to basically start with our basic clinical skills. I'm going to discuss a case scenario, and then I'll be discussing about the facts and figures of interstitial lung disease. So I'll be starting with this 62-year-old gentleman who is an ex-smoker, presented with progressive shortness of breath from MMRC1 to MMRC4 for 1 year duration. He also complained of cough with production of scanty amount of sputum, and the cough showed diurnal variation too. He was prescribed a steroid inhaler, that is beclomethasone MDI, with minimum clinical response. The examination revealed clubbing with bibasal late inspirated fine crackles involving the lung bases. So this is our case scenario. And you know that we should know our basic sciences. What are the crackles, the definition? If you refer to this Macleod's clinical examination, I'm sure that you'll be aware of this kind of a clinical examination book, which we studied at our undergraduate time. So the definition is crackles are interrupted non-musical sounds and the results from collapse of peripheral airways on expiration. On inspiration, air rapidly enters these distal airways and the alveoli and small bronchi open abruptly, producing the crackling noise. And if you go for the causes of these crackles, as you are aware, there are fine crackles as well as post crackles. It could be early inspirated crackles, which commonly due to small airway disease like bronchiolitis obliterans, or it could be due to middle inspirated crackles in pulmonary edema, or it could be late inspirated crackles due to pulmonary fibrosis. Usually they are fine crackles. And you might hear these fine crackles on late inspiration due to pulmonary edema too, and also in COPD due to bronchial secretions. So what further details are required? I mean, we have a clinical scenario and we examine the patient. Now we are defining that there are bibasal lung crackles involving the lung bases, as well as there's cross-clubbing. And if you consider the history, what are the aspects that we should take further? For example, you should assess what is the onset of the shortness of breath, whether it is an acute onset or whether it is a gradual onset shortness of breath. And the progression, whether it is a rapidly progressive shortness of breath, whether it is intermittently progressive, or whether it is very quietly or gradually progressive. And the severity, of course, we know what is the severity, whether it's MMRC1 to MMRC4, it has been given in the history, and the aggravating factors. What are the factors which aggravate the shortness of breath, whether exposure to dust, exposure to fumes and smoke, whether they aggravate, whether exertion aggravates this, and what are the relieving factors, whether inhalers are relieving his symptoms. And then we should ask about associated symptoms. Particularly, we should ask about cough, the sputum production, hemoptysis, red flag symptoms like appetite loss and weight loss and all. And then we should ask about the CTD features. So the patient has any skin rashes, photosensitivity, arthralgia or arthritis, myalgia, myositis, these side of features, and Raynaud's phenomenon has to be asked. And then we should go for in details about exposures like organic exposures, inorganic exposures, and substance abuse, basically, which all can lead to these respiratory problems. So what are the differential diagnoses then? Obviously, in a patient of this stage, when coming with shortness of breath and with significant exposures like smoking and bibasal crackles and clubbing, we should think about interstitial lung disease. Asthma and COPD overlap is also possible, as I said before, and cardiac failure is also possible, especially if the patient is having orthopnea and angina, if the patient has paroxysmal nocturnal dyspnea and all. So these are our differential diagnoses. So this is the X-ray, as you can see. In this X-ray, you can see that the cardiac size is almost normal, but in the lung bases, you can see the reticular opacities. And if you consider the height between the hilar and the diaphragm, it is reduced. So we can predict that this patient has a volume loss in the inferior aspects of the lung. So this predicts this patient has probably of a interstitial lung disease than cardiac failure or COPD. In COPD, we see it is hyperinflated lung fields in contrast to the volume loss as we see in this patient. So we have conducted a HR-CT on this patient, and the HR-CT revealed there are a bilateral middle to lower zone reticulations with interstitial thickening, and there are some areas of honeycombing. I'll come to that discussion with minimum ground glass. And furthermore, we assess the etiology with ANA, rheumatoid factor, and other exposures, and it was negative apart from the smoking. And we did an echocardiogram. We found this patient has mild pulmonary hypertension too. The physiological assessment, which includes the spirometry, DLCO, as well as the 6-minute walk test, which revealed that there's a moderate restriction in the gas transfer. So when you consider our overall diagnosis, anatomically, we know that there are bilateral mid to lower zone involvement, that is a moderate extent lung disease. The pathology, we know it's interstitial lung disease. And etiology, we could not find any etiology from the exposure or from the investigations. So most likely it's idiopathic, and he has been complicated with early pulmonary hypertension, and he has been disabled with limited activities of daily. So these are full diagnosis for this patient. Is idiopathic pulmonary fibrosis, and which has been causing limited daily activities for this patient, has been complicated with early pulmonary hypertension. So this patient has been assessed by our team, and we assess clinically, physiologically, and we back them with clinical education. Basically, we kind of educated about the condition, the prognosis, and we advised them about exposures, about prevent smoking, and we recommended vaccination, particularly the influenza vaccination as well as pneumococcal vaccination in addition to the COVID vaccine. And then we comfort. We basically we cared about the symptoms of shortness of breath. We continued to go for a kind of symptom control measures, as well as we looked carefully into the comorbidities conditions like obstructive sleep apnea and cardiovascular comorbid conditions as well. And then we offered this patient on disease-modifying treatment, which is antifibrotic therapy with pirfenidone. And also we discuss about the palliative aspects of his care, which includes end-of-life care. So these are our overall management for this patient, which can be categorized as A, B, C, D, E approach for this patient with interstitial lung disease. All right, so this is our case. We has been diagnosed and offered treatment according to a certain protocol, and we will try to understand interstitial lung disease. So by definition, interstitial lung disease is a group of non-neoplastic disorders resulting from damage to the lung parenchyma by inflammation and fibrosis that diminish the lung capacity for alveolar gas diffusion. And a diagnosis is a dynamic process. There should be often interaction between the clinician, radiologist, as well as pathologist. And ultimately, we should come to a multidisciplinary diagnosis. It is not a single disciplinary diagnosis. Remember that we should have to have a multidisciplinary diagnosis for interstitial lung diseases. If I consider the updated classification of interstitial lung disease, it can be broadly divided into interstitial lung disease with known causes, for example, like connective tissue disease associated interstitial lung disease, occupational associated interstitial lung disease, or drug associated interstitial lung disease, or interstitial lung disease which causing granulomas, which include sarcoidosis, hypersensitive pneumonitis, and some of the chronic infections. And then other forms like lymphangioma, lymphangiomyomatosis, or histiocytosis, which are rare forms. And the majority of the interstitial lung disease, we can't find a particular cause, which is known as idiopathic interstitial pneumonias. These idiopathic interstitial pneumonias can further divide into epidemiology as well as clinical behavior. There are major interstitial pneumonias as unclassifiable interstitial pneumonias. The major interstitial pneumonias include chronic fibrosing forms, which are idiopathic pulmonary fibrosis and non-specific interstitial pneumonia, and smoking-related, which are desquamative interstitial pneumonia with respiratory bronchiolitis interstitial pneumonia, and acute and subacute interstitial pneumonias, which includes cryptogenic organizing pneumonia with acute interstitial pneumonia. Then we should evaluate for the etiology. We should get from the history about the CTD features, the organic and inorganic exposures, the substance abuse, smoking, and drug exposures, and also extrapulmonary manifestation. By then, we can come to a etiological assessment. And if the patient has, particularly the patient is a female, less than 50 years, with certain radiological patterns of NSIP or organizing pneumonia, and we have to consider that it's most likely due to CTD. And when to suspect drug reaction, if the patient with recurrent urinary tract infections, patients receiving chemotherapies, radiological patterns of organizing pneumonias and all, we have to consider it's a drug reaction. Other organ involvement include premature graying, that is, and cryptogenic cirrhosis, aplastic anemia, macrocytosis, and thrombocytopenia. If these kind of diseases are associated, we have to always think of familial lung fibrosis in this patient. So next, actually, we have to do the imaging. The imaging is done by volumetric high-resolution CT scan of the chest. We compare to the traditional interspace CT scan, which we can assess the entire lung volume and with high resolution. So then we can go for a pathological diagnosis, which includes surgical lung biopsy, transbronchial biopsy, or transbronchial cryobiopsies, which is not available in our setup, and bronchial large cell count. If you consider the surgical biopsy, which has been considered as a gold standard for diagnosing ILD, but the issue is that it has a very high mortality and morbidity compared to the other biopsy techniques. For example, the morbidity of surgical lung biopsy carries about 15% and mortality of 8% compared to renal biopsy morbidity about 11% and mortality of 0.1%, and a liver biopsy of morbidity about 6.4% with mortality about 1.6%. So therefore, surgical biopsy has been kind of removed or kind of less prioritized in the diagnostic algorithm of interstitial lung disease purely because of the high morbidity and mortality when compared to the other biopsy techniques. Therefore, this new technique of transbronchial cryobiopsy has been kind of developed, which is not available in our setup, but it carries a very fairly good mortality and morbidity figures compared to the surgical lung biopsies. Then about the biomarkers, I mean, it's a very complex diagram of immunology of interstitial lung disease. You can check each and every aspect of these biomarkers and come to a biomarker. But again, it is not developed very well in our setup in Sri Lanka. In our diagnostic workup, if I summarize, we have to define the clinical context. That is the most important aspect of our ILD diagnosis. We have to define the extent of the disease. We have to identify the etiology. You might consider there's no etiology. In that case, we will consider as unlikely to be interstitial pneumonia, idiopathic interstitial pneumonia, or we might find exposure. We might find CTD features. We might find pneumotoxin exposures and all. In that case, we can define this as idiopathic interstitial pneumonia. So history is uttermost important in evaluating interstitial lung disease. Then the imaging, which includes a classical high-resolution CT scan of the chest, we can identify the pattern and extent. In certain, most of the time, that there's a diagnostic pattern which correlates nicely with the histology, and in certain cases, it might not be diagnostic so often. So in that case, we'll go for MDT, and we'll come to a confident diagnosis of interstitial lung disease. And if we know the diagnostic patterns of pathology as well as radiology, if it is not, we'll come to a working diagnosis. So how do you come to a radiological diagnosis of interstitial lung disease? So there are kind of guidelines as well as radiological protocols available. First, we evaluate the CT scan from the epices to the lung bases in an axial film, as well as in sagittal, as well as coronal films. We'll try to identify certain patterns. The first pattern we try to identify whether it is a UIP pattern. For example, if the distribution is basal predominant, and if it is subpleural, and if there is honeycomb, there's this like cyst-like lesions, and there's traction bronchiectasis, we know it is a UIP pattern. And if we can't find these four features, in that case, it could be still subpleural, predominant, it may be subtle reticulation without any honeycombing or without any traction bronchiectasis. We might consider as an indeterminate for UIP. But if the CT has kind of more cyst, more nodules, more predominant ground glass, and the distribution is not craniocaudal, if it is peribronchovascular, perilymphatic, or other pleural plaques and dilated esophagus, and these instances, we might consider alternative diagnosis depending on the findings. So this our first etiology is first radiological pattern that we are going to look is UIP, and if it is there, we diagnose as UIP, and if it is not, we'll go for alternative diagnosis depending on the radiological findings. For example, this CT scan, you can see there's traction bronchiectasis and reticulations, and the distribution is craniocaudal with some honeycomb cyst involved in the lung bases. So therefore, we can list this as a UIP pattern interstitial lung disease. Then I'll discuss about the historical achievements in the management of interstitial lung disease. And there are certain principles and there are certain advances in the pharmaceutical as well as non-pharmaceutical management. There are three basic principles that we should adhere when you're managing interstitial lung disease. Number one is that we should come to a dynamic approach. It should not be a single discipline approach. We should always approach the radiologist. We should always approach the pathologist, and if we might approach the rheumatologist, and we should come to a interdisciplinary or multidisciplinary diagnosis of interstitial lung disease. There is evidence-based approach for diagnosis. It should not be a single specialty. For example, if the radiologist says if it is UIP, you should not consider this as a kind of a UIP. You should come to a conclusion, because there are certain etiologies of UIP which makes it either IPF or non-IPF pattern. So therefore, it should be always a dynamic approach. And then this PANTHA-IPF study, which is conducted in 2012, which gave a nice kind of message to us that we should have to have a diagnostic certainty before offering any treatment for these patients. That means that we should not guess that it could be steroid response. Okay, any patient with ILD, we should offer treatment with steroid. We should not do. Therefore, we should come to a diagnostic certainty before offering any treatment. Number three is actually that it is coming from the ATCRS guidelines in 2013, that we should discuss with the patient what is our intention of treatment, and we should plan in advance. For example, there are certain interstitial lung diseases that we can't offer any cure, and certain interstitial lung diseases that we can only stabilize the disease, and certain interstitial lung disease we might achieve complete resolution. So therefore, with the patient, we should discuss what is our intention or objective of treatment, and we should plan in advance. For example, if we consider chronic fibrosing ILDs, for example, idiopathic pulmonary fibrosis or fibrotic NSIP, the natural disease progression is it can progress rapidly or sometimes slowly. Therefore, our treatment, this is disease-modifying agent, antifibrotic, namely the pirfenidone or nintedanib, will only reduce the rate of progression. Therefore, the patient feels that his symptoms are progressing throughout, and but the treatment is only reducing the rate of progression. And there are certain chronic fibrosing ILDs like chronic hypersensory pneumonitis, where we can achieve the stability at the time of diagnosis. For example, the patient will feel the same throughout with the treatment. Again, that we have to discuss with the patient, as sometimes that patient might default treatment saying that there's no improvement, but our aim is to achieve the stability of the disease. And there are certain reversible and self-limiting diseases like respiratory bronchiolitis interstitial lung disease or desquamated interstitial pneumonia. In that case, we can achieve complete remission. Patient can be as same as before. So that has to be discussed with the patient. And there are certain kind of diseases like cellular NSIP and subacute hypersensitive pneumonitis where we could offer treatment to achieve improvement and then a stability of the disease. I'll discuss again basics of the pharmacological management. I mean, before 2020, there are very scanty number of studies for interstitial lung disease, but as you can see, after 2000, there's a number of studies, more than about 35 studies has been conducted to diagnose a solution for particularly interstitial kind of idiopathic pulmonary fibrosis. And they have been studied more than 30 substances to come to a conclusion what is the possible treatment for this condition. But however, there's only 2 clinical trials has been kind of found disease-modifying agent for these fibrosing lung diseases. But they have studied many molecules. So however they studied, but even though that there are so many negative studies, they gave us a very clear message to us saying that these drugs may not be effective, but it gave a clear kind of message that we should be, which define the kind of pathophysiology of the disease. There are landmark clinical trials, as there are many PG trainees here. I'll discuss few landmark trials. Number one is the 2005, the pirfenidone trial, which has been introduced by the Japan. And then the capacity trial came in 2011, which they have studied further the efficacy and safety of pirfenidone. And then that has been confirmed in America, which has been designed by the FDA 2014, which shown the efficacy and safety of pirfenidone. And then in 2014, the Impulses trial came, which showed the efficacy of nintedanib, the tyrosine kinase inhibitor, how effective it is. And meanwhile, there are a few negative trials. 2005, the Iphigenia trial, which has been studied prednisolone, azathioprine, and N-acetylcysteine combination for the treatment of idiopathic pulmonary fibrosis, where they have found a mortality benefit in combining this combination for IPF. But when the same question has been studied in 2012 at Tanta IPF, they found that it is not, this combination in fact increases the mortality, and therefore this study has been terminated early because of the high mortality in the treatment arm. Then they went back to this Iphigenia study, and they found that there's the diagnosis was inadequate or incorrect in certain instances. They have recruited some other diagnosis for that particular cluster of IPF. Therefore, there is some response to the immunosuppression. But when you have a clear inclusion criteria for the IPF diagnosis, they found that there's no mortality benefit. In fact, there's harm to the patient by giving this prednisolone, azathioprine, and NAC combination. So these are the 2 molecules that we operate for the disease modifying in this setup. Nintedanib is a tyrosine kinase inhibitor, as well as pirfenidone, is a pyridine derivative. And if you consider systemic sclerosis interstitial lung disease, which is another very interesting interstitial lung disease pattern, it has been found that 35% or majority of the systemic sclerosis deaths are due to systemic lung fibrosis, and we can detect at least 90% of the time if you do a CT scan in systemic sclerosis. And 40 to 75% of the patients exhibit abnormalities in lung functions. Therefore, every patient with systemic sclerosis should and must undergo a chance CT scan at the baseline to see whether they have interstitial lung disease. And high-resolution CT scan mainly show the NSIP pattern as a classical pattern of interstitial lung disease in systemic sclerosis. There are 3 clinical trials which are landmark trials for systemic sclerosis. The Scleroderma Lung Study 1, which they combine oral cyclophosphamide versus placebo, which found the efficacy of oral cyclophosphamide against placebo. However, the tolerability became an issue and the toxicity became an issue. Later, they have found that IV cyclophosphamide pulses are superior for the oral cyclophosphamide in terms of safety and efficacy. And the Scleroderma Lung Study 2, which they have compared the mycophenolate and mofetil versus cyclophosphamide, which found that there's no additional efficacy benefit, but there's a good safety profile with mycophenolate, which become the mycophenolate the treatment of choice or the standard of treatment for interstitial lung disease of systemic sclerosis. And Scleroderma Lung Study 3 is still being kind of conducted, which is pirfenidone and mycophenolate combination for systemic sclerosis, and which is still being studied. And then the myositis interstitial lung disease, its classical feature of myositis ILD is that most of the patients which demonstrate myositis might not have ILD. And patients who demonstrate ILD, they might have biochemical or radiological evidence of myositis, but without any clinical evidence of myositis. So therefore, rather than a syndrome-based diagnosis, we are considering about serological diagnosis in terms of CTD, particularly about myositis spectrum diagnosis. And I'll try to brief about this new phenotype of each ILD, which is progressive fibrosing ILD. So each and every ILD we discuss about hypersensory pneumonitis, or if you consider CTD ILD, sarcoidosis, and exposure-related occupational ILDs, about 20 to 30% of this population, they tend to progress whatever the treatment you offer. So that is known as progressive fibrosing ILD phenotype of this diagnosis. So therefore, it could be, which can be detected by worsening symptoms irrespective of the treatment, deterioration of health rate, quality of life, and increased fibrosis markers in high-resolution CT scan, and their gradual decline in their lung functions with standard treatment. So we now know that these patients can be offered antifibrotic therapy, predominantly the nintedanib. Right. If I summarize my topic, I'd like to kind of highlight the fact that when you consider interstitial lung disease, it is important to have a multidisciplinary approach, and we should have a discussion about the with the radiologist, with the pulmonologist, with the pathologist, and with the rheumatologist to come to a conclusive diagnosis. And we should have to have a diagnostic certainty before offering treatment, and also that we should discuss with the patient regarding the prognosis and our intention of treatment before offering treatment. Don't offer any blanket therapy of steroids for these patients with interstitial lung disease. This is behaved differently in different interstitial lung diseases. And I'd like to thank again the organizers, particularly the Ceylon College of Physicians, as well as the Ceylon College of Pulmonologists for organizing this session. And I'm happy to answer if there are any questions. And thank you so much.
Thank you very much, Amila, for that very brief introduction, very informative and concise lecture that covered almost everything that we need to know in the management and the understanding of IPF. I just have a question that just came in. Yeah, the question is that systemic sclerosis ILD is steroids not used due to the scleroderma renal crisis, and they want to know what's the mechanism of the renal crisis with steroids.
Yeah, so basically, I mean, in a systemic sclerosis interstitial lung disease, and we do not prescribe higher doses of prednisolone or steroids. That is purely because that it can precipitate a renal crisis. And there's a kind of, therefore, routine recommendation is actually for long-term use of steroid. We usually tend to don't give more than 15 milligrams of prednisolone, but we can use low-dose systemic sclerosis. And if there's any evidence of kind of diffuse cutaneous systemic sclerosis, and in that case, we can kind of consider ACE inhibitor therapy when you are considering kind of this a steroid therapy for systemic sclerosis. And the pathophysiology, again, renal crisis, it has been kind of multifactorial, and what they kind of tend to kind of, it is not, has been kind of clearly evaluated, but high dose of steroid seems to be kind of impairing the renal perfusion as well as secreting a lot of kind of activating the renin-angiotensin and aldosterone axis in the renal pathway and causing this malignant hypertensive type crisis. But I must say this is not very kind of common. I have not seen for my life the renal crisis, but generally, I mean, we do not offer high dose steroids beyond 15 milligrams of prednisolone.
Thank you. We have another question from Dr. Chanaka, who wants to know what is the rough distance? I suppose when we are taking the measurements, he wants to know the rough distance from the hilum to the diaphragm.
Yeah, usually, I mean, the hilum to diaphragm, usually the hilum to the lung apices and hilum diaphragm should be equal in a normal patient. So that's how we get. So if the diaphragm to hilum is smaller than diaphragm to the, hilum to the apex of the lung field, and in that case we know there's a volume loss. So basically it should be equal in a normal person.
In the interest of time, I think we're going to, I can take one more question. From an anonymous attendee wants to know, when do we suspect pneumonitis due to methotrexate? And what is the usual, when does it start, the duration of initiating methotrexate? Would you usually get pneumonitis?
Yeah, so I mean, methotrexate has been kind of considered as a pneumotoxin, but now the prospective studies has been kind of revealed that methotrexate is not as toxic as other pneumotoxins like leflunomide. So, I mean, the current evidence comes is a kind of methotrexate is not a classical pneumotoxin, because when you start methotrexate early in the disease, we know that it has a lung protective effect. But anyway, if you're suspecting methotrexate pneumonitis, which is rare, and we know that it is mostly lung protective now, so therefore you should not kind of stop methotrexate whenever there's ILD. But if you're suspecting kind of methotrexate in the pneumonitis, we should discontinue it. But even in a background of interstitial lung disease, we can continue methotrexate until the DLC is less than 40% usually. So we should remember that we should not discontinue methotrexate as soon as a diagnosis of ILD made. We can continue methotrexate irrespective of the ILD until their DLCs drops to up to 40% of their baseline.
Thank you very much, Dr. Miller, once again. With the interest of time, we'll have to conclude the Q&A session now, and we'll move on next to our next speaker, who will be speaking to us on a topic that's very relevant with the current situation in Sri Lanka. I'd like to invite Dr. Samanmani Dalpadadu, who's currently the consultant respiratory physician at Teaching Hospital Karapitia with a special interest in sleep medicine. She will be talking to us today on optimizing COPD care to overcome the health burden during the current economic crisis. Without taking much time, I'll hand it over to you, Dr. Samanmani. Take over.
Thank you, Dr. Yas. So my talk will be on optimizing COPD care to overcome the health burden during the current economic crisis. Thank you for this opportunity. So I'll move into my case history. So it's a 70-year-old retired mechanic father of three children presented to the respiratory clinic with progressive breathlessness and associated cough for a few months, which did not respond to inhaler therapy. There has been multiple visits to doctors with the same complaint. On further questioning, he mentioned that he lost significant weight over the past few years. He is fed up of questions by his neighbors with asking about why you are so about his weight loss. The exact exercise capacity of this patient was difficult to evaluate by history per se, as he was largely sedentary and travels even shorter duration distance by motorcycle. He worked abroad for more than 10 years in the past and had been a chain smoker and stopped smoking 15 years back. So his children, being well-educated professionals, take good care of their father, yet the whole family were desperate about his condition. On examination, he is wasted in distress, not dyspneic. Respiratory system examination, barrel-shaped chest, bilateral diminished breath sounds, few rhonchi. So clinically, the diagnosis of COPD and chest X-ray, lung functions done, both confirm the diagnosis. So I'll move into my topics today. COPD is a very common disease globally. Are we the same? The pathogenesis, COPD overlaps. Clinical evaluation, diagnosis, and pharmacological management. Last but not least, how to reduce the healthcare burden by COPD management optimization. COPD is a highly prevalent disease. The estimated global prevalence of COPD was 10.3 in 2019. COPD is accounting for 391.9 million cases among people aged 30 to 79 years on the basis of GOLD definition. Chronic obstructive pulmonary disease is the third leading cause of death worldwide, causing 3.23 million deaths in 2019. Nearly 90% of COPD deaths in those under 70 years of age occurs in low and middle income countries. That is the important aspect. More than 90% of COPD deaths happens in low and middle income countries. What about the COPD prevalence in our country? Our colleagues has done a study in 2017. They have highlighted the prevalence of COPD in Sri Lanka adult is similar to global and regional prevalence. That is, overall prevalence was 10.7 and majority is in stage 1, 85% of them. Recently published systematic analysis in a Lancet. It's a systematic analysis for the global burden of disease study 2019. They have studied 369 diseases. So there I quote one significant finding. Already low income and middle income countries account for 62.6 global burden of COPD and lung cancer. And this share is likely to increase sharply over coming decades due to aging populations and less successful tobacco and air pollution control. The same article has mentioned that in 2009, this is the Sri Lanka, the 10 top causes for deaths. So COPD has been in 8th in 2009, 8th place. Now it's gone up to 6th. So, but I doubt this asthma is ranking 4th. We know as a clinician that pure and simple asthma, the deaths are now coming down and down, but still they carry without the proper lung function test, chest X-rays, people might carry a diagnosis card saying asthma, and when they after decades, when they die, the death certificate carries the name asthma. But I doubt whether these are asthma, pure asthma, or asthma COPD overlaps. So in clinical context, I think the 6th number will go higher up. So COPD, chronic obstructive pulmonary disease, is a condition characterized by persistent airflow limitation that is usually progressive and is associated with the chronic enhanced inflammatory response in the airways and lungs to noxious particles. So I want to highlight that it's a persistent airflow limitation, which is not going to reverse like in asthma, and usually progressive. So usually progressive. Cigarette smoking is the main etiological factor, but other risk factors are also understood. Biomass fuels, so many. So pathogenesis, what will happen? All smokers don't ended up in COPD, but all smokers develop lung inflammation. This is enhanced and fail to resolve after smoking cessation in those who develop COPD. This suggests that in smokers who develop COPD, there is abnormal regulation of the inflammatory response in the lungs. So susceptibility factors are poorly understood. Maybe genetic, maybe infection, maybe altered immune regulations. We don't know. Maybe in some cases, we don't know actually. So what is happening in the lungs? So cigarette smoke or whatever the noxious particles come to the lungs. Epithelial cells, alveolar macrophages start damaging, and this tumor growth factor, CD8 lymphocyte damage, neutrophil, all are happening at the same time. So as a result, oxidants, proteases released into the circulation will lead to fibrosis, destructions, and mucus hypersecretion. So submucous bronchial gland enlargement, goblet cell metaplasia result in excessive mucus production. So multiple things happening in the lungs as a persistent thing, and ended up with the chronic obstructive airway disease. It's a multifactorial process which is progressive and inflammatory based on. So clinical entities, chronic bronchitis, emphysema, those are clinical entities of COPD. So chronic bronchitis is defined in clinical terms as the presence of cough or sputum production for most days over 3 months for 2 consecutive years. So inflammation is present in the epithelium of the central airways and in the mucus-producing glands in chronic bronchitis. This airway inflammation is associated with increased mucus production, reduced mucociliary clearance, and increased permeability of the air space epithelial barrier. So as a result, they are coming with a productive cough. Emphysema, what will happen to them? Their emphysema is defined as enlargement of the air spaces distal to the terminal bronchioles due to destruction of the alveolar walls. Distal air space enlargement with alveolar destruction reduces maximal expiratory airflow by decreasing the lung elastic recoil. That is what happened in emphysema, the loss of elastic recoiling. This is the pathology. So everywhere the small alveoli are distorted. Pan-acina emphysema, centriacina emphysema, pathological differentiations. Rather than just seeing a chest X-ray, the real-time CT might help us to understand what happened in the lungs. So this is a emphysematous lung with the air trapping areas, lot of air trapping areas. So when they exhale, this much of air will trap rather than exhaling. So their residual volume is high. So when this is called as dynamic hyperinflation. So when they are at rest, it is not big. It's not a significant issue. So their inspiratory capacity, inspiratory reserve volume, and tidal volume are in normal. So they breathe well, but when they start exerting, when the rates are increased, the inspiratory capacity is reduced because of the residual air is the residual volume, residual air is increased, so their capacity is reduced, so their rate will be increased. As a result, their expiratory time is reduced, so this will start as a vicious cycle. What about pulmonary circulation with the COPD? So factors that contribute to pulmonary hypertension, pulmonary arterial constriction as a result of hypoxia, endothelial dysfunction, remodeling, destruction of pulmonary capillary bed. So parallel to the COPD, patient will develop pulmonary hypertension as well. So this is natural history of COPD. If they stop their smoking, it will reduce the damage. So the lung FEV1 reduction will be slowly reduced. But if they continue to smoke, then they are drastically FEV1 will be reduced. So as we talk about these risk factors, smoking, biomass fuel, occupational exposures, genetic asthma, all these can contribute. So COPD, clinical characterization of COPD. It is highly heterogeneous. The common respiratory symptoms are breathlessness, cough, and expectoration. This heterogeneous character, because it's highly heterogeneous, it's very difficult to understand, predict FEV1 of the patient when we come across the patient. So we have to do the lung function to see how bad their FEV1. So clinical markers such as presence or increase in symptoms, rate of FEV1, decline, frequency of exacerbation, unintended weight loss, poor exercise capacity, imaging, X-rays, HRCT. So when we examine the patient, we can see that they are in distress, depressed. Their faces looks very anxious. Patient may breathe in a tripod position in which the individual leans forward and support his or her upper body with extended arms. This maneuver takes advantage of accessory muscles of the neck and upper chest to increase air movements. Patients with severe disease may also use pursed lip breathing, which involves exhaling through tightly pressed pursed lips. This technique creates back pressure and is thought to reduce dynamic hyperinflation, although it may also work by reducing bronchoconstriction. So their body is adapted to the physiology, trying to adapt. So as I showed in the case, chest X-ray, hyperinflation, and spirometry will show obstructive lung disease without significant reversibility. So you have made a diagnosis according to FEV1 predicted percentage, gold classification, 1, 2, 3, 4, or the newer way of classifying with the with all these things considering as A, B, C, D. So the A means you have got a MMRC 0, CAT score, which patient is responding their clinical symptoms, and 0 to 1, there is no hospital admission. Then patient will be categorized as as A. So A, B, C, D. This is a very good classification of a COPD patient in view of their prognosis. So COPD as it's a heterogeneous disease, it has some phenotypes which have already validated. The one is alpha-1 antitrypsin deficiency, where we rarely see these patients in our country. The second one is upper lobe emphysema with poor exercise tolerance even after rehabilitation. So those patients might respond to volume reduction surgery. Third, people are having frequent exacerbation with no cause. The fourth one is combined emphysema and lower lobe fibrosis, very poor prognosis people. So those are COPD phenotypes. There are people who come as a COPD overlaps. COPD overlaps are bronchiectasis, COPD, fibrosis, COPD, OSA, COPD. Those are COPD overlaps. So we have to, so for example, if an OSA patient coming with a pulmonary hypertension, we have to look for a COPD. So like that. So COPD overlaps COPD asthma. So those are COPD, those people, other than the asthma, they are having the COPD component as well. The patient with the bronchiectasis, most of them have a COPD component as well. Even though their bronchiectasis part is treated, they are still symptomatic. So that is the active part of a COPD. So like that, COPD overlap syndromes are there. So one size is not going to fit all in COPD. Post-TB obstructive airway disease. This is a very clear entity. We have seen a lot of patients who has treated for TB, cured, but still they are symptomatic. So it might be COPD, post-TB COPD. So like that, those are overlaps. So we might not identify their COPD element. Therefore, we are not thinking of treating that element. So patient will be continue to have symptoms. So when we diagnose COPD, what is the treatment? Until recently, treatment of COPD was focused entirely on relief of symptoms. Symptoms of treatment options were few and were believed to be largely ineffective. Patients are on treatment, but still they were suffering. In fact, the literature reported that only intervention that changed the natural course was cessation of smoking, agreed. But now aims are prevent exacerbation, prevent disease progression, improve exercise tolerance, and improve quality of life. Those are the aims. Now we have changed all the practice in COPD management. So why we are preventing exacerbation? Not only to reduce the health burden, but same time, if the exacerbation happens, the FEV1 is drastically drops and it takes a long time to come back to the baseline. So prevent exacerbation are very much important in COPD patients. So reduction of risk factors, stop smoking. It's another topic that I should be talking to, but because of the time issue, I will not going to touch. But it's the most important aspect of treating COPD patient with the smoking. Avoid biomass world, modifying environment, prevent of respiratory infection, more susceptible to respiratory infection because of impaired mucociliary clearance in these cases. I showed you that pathophysiology, so they don't have mucociliary clearance as such. More susceptible to consequences of respiratory tract infection. So therefore, to prevent recurrent infections, they should be immunized for influenza, streptococcus pneumoniae, COVID, all these. So pharmacotherapy, standard therapy consists of inhaled bronchodilators, ICS, oral agents, phosphodiesterase, oral corticosteroids. So those are the pharmacotherapy we have to treat accordingly. Bronchodilators are recommended for all patients with COPD. Unlike asthma, where bronchodilators reversibility is part of the definition, airflow obstruction in COPD is often thought as irreversible. This is not, however, completely true. Even though it is irreversible, even slight increase in FEV1 may be a modest because it may sufficient to improve the lung emptying, which I was talking to you before. Then it will, by that mechanism, it reduces dynamic hyperinflation. Even FEV1 slightest improvement will help us to reduce the dynamic hyperinflation, which is a vicious cycle, will be start reversing. So bronchodilated in stable COPD, there are evidence. This is taken from the gold statements. So a combination of LABA and LAMA increases FEV1, reduce symptoms compared to monotherapies. There are so many evidence-based treatments for COPD. Anti-inflammatory therapy in stable COPD in ICS combined with LABA is more effective than the individual component in improving lung function and health status and reducing exacerbation in patients with exacerbations and moderate to severe COPD. Those are evidence A. Regular treatment with ICS increase the risk of pneumonia, especially in those with severe disease. So we have to come down the ICS in these patients. So initial pharmacological therapy according to group A, B, C, D, we will start and we will monitor these people. So prophylaxis antibiotics we might consider in these people. So we have started treatment, stop exposure, start inhalers, identify phenotype, overlaps, treat those as well, vaccination, prophylactic antibiotics. So all this done. So now where are we? As I started the case, that patient had stopped smoking years ago, and he was started on inhalers, but still he is suffering, and he's going to doctor shopping because he's not relieved. Family doesn't know what is happening. They can't understand. So have we treated the COPD patient? No, not really. What about the health economy? In the Europe, the places where the properly calculated economic cost, in European Union, the total direct cost of respiratory diseases are estimated to be about 6% of the total health budget. COPD exacerbation account for the greatest proportion of the total COPD burden on the healthcare system. As we were discussing, it's the third leading cause for death. especially hospitalization cost, which increase rapidly as COPD severity increases. When the severe COPD patient, we can see regularly they admit to the hospital, multiple hospital admissions. Particularly in developing countries, the impact of COPD on workplace, workforce, and home productivity outweighs the direct costs for the disease management. In Sri Lanka, the total health expenditure is from GDP, it's 3.9 in 2016. So we wanted to reduce this health burden. So when we go with some systematic review, cost analysis of chronic obstructive pulmonary disease, they come in terms like why these increases, because COPD patients has number of exacerbations, can lead to so many visits to the emergency department, hospitalization. Those generate high cost, which in addition to the patient own comorbidities can be lengthy, because these COPD patients have underlying other diseases like ischemic heart disease. When they come with a COPD exacerbation, they might go into a precipitating ischemic event. So their hospitalization may be lengthy. Greater consumption of drugs, greater hospital and outpatient visits, the performance of greater functional and laboratory tests directly and indirectly affecting parameters that make up work losses. Maybe the bystanders, the family members, they can't go to the work. So enormous health burden, increased disability. The patient might start depending on others. So loss of health-related quality of life. So everything together will attribute to this health cost. So what should we do? Review symptoms, dyspnea, exacerbations, assess inhaler technique, adherence, non-pharmacological approaches. Again, escalate, de-escalate, switch inhaler device, molecules. Those are the management cycle. So we have to go on this cycle again and again and again. The COPD is very common, but it's overlooked. Why? Patient is not going to tell us I am having COPD because it happens over years and years. In general, they themselves restrict their physical exercise gradually, so they are not aware about the gravity of dyspnea. Like in my patient, he does. When I ask when you walk little, but he has not been walking. He always uses motorbike. Cough and sputum production in COPD is often more variable than the presence of dyspnea, so it can significantly impact quality of life. So patient might not come across with a diagnosis. So we have to suspect. So COPD name itself is a misleading. Why? It's a systemic inflammatory disease. We are talking about lungs only. What about other things? Skeletal muscles, cardiovascular, metabolic, bone, and other associated psychological impact. So we don't talk about all these things. We just talk about skeletal muscles and weakness. We will focus on those. This is one survey done by a European country, where patients' symptom perception is totally different to the doctor's perception. Even we are being a doctor, we might not perceive the patient's difficulty. Patient is in the here more than 3. We think that the patient is in here. So this is not perceived by the doctors. So all COPD patients are wasted. No, because COPD, there is a people who can come with obesity and COPD, OSA COPD. So it's not a proper word to say wasted, but they are sarcopenic. Yes, they are sarcopenic because their muscles are wasted. They are low muscle mass, reduced muscle strength, and physical performance. So altogether, the presence of all 3 criteria causes severe sarcopenic. They are severely sarcopenic. So all size is not fit for all, but pulmonary rehabilitation is the only way that we can reverse all these things and start treating them. What is pulmonary rehabilitation? A comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies that include but are not limited to exercise training, education, behavior change, designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence to health enhancement. This is the definition, but when we do the practical, we'll see what is it only the exercise training? No, it has all these elements. What is the expected outcome? Is it going to change the lung function test? No, but it improves the dyspnea. It improves the 6-minute walk distance, which reflects the systemic nature of the disease. Exercise tolerance, mid-thigh cross-sectional and mid-arm cross-sectional areas, muscle mass are better predictor for the survival than the lung function. So emerging data suggests that it may also be beneficial for other chronic respiratory diseases as well. So exercise training, upper and lower extremities, endurance training and strength training is an essential component. So what has already happened? Sarcopenia, peripheral muscle in patients with chronic lung disease are not only wasted, but also appear to have alterations in fiber type distribution and decreased metabolic capacity. As a result, what has happened? Exercise training improves endurance, increase the level of functions, aid in performance of activities of daily living, helps reduce systemic blood pressure, improves lipid profile, tend to counteract depression, reduce anxiety associated with dyspnea, producing activities, and facilitate sleep. Intensity, higher levels of training produces more result. Specificity, only those muscle trained shows an effect. Reversibility, cessation of regular exercise training leads to loss of training effect. Exercise capacity in many patients is also limited by peripheral muscles and cardiovascular deconditioning, with an early onset of anaerobic metabolism and the production of lactic acidosis during the exercises. Therefore, they get pain in the exercises, so they tend to stop their mobilization. Muscle cramps are very common among them. So many respiratory patients are capable of exercising for a prolonged period of time at level close to capacity, but the higher level of exercise training results in greater improvement in exercise performance. The demonstrated reduction in ventilation and lactate level at identical submaximal work rates following high-intensity exercise training strongly suggests that the training effect is attainable in many patients with advanced lung disease. The reduction in lactic acid production has been demonstrated to be associated with improvement in oxidative capacity. So most pulmonary rehabilitation program has been going on for 20 to 30 minutes to 20 to 30 minutes, 2 to 5 times a week.
I just want, sorry to interrupt, we have only 5 minutes more, Dr. Samanmali.
Okay, so I will concentrate on what we were doing. So, so overall, it's a multidisciplinary teamwork. The involved team are doctors, nurses, physiotherapists, members from the human nutrition, members from the psychology. To have sustainable benefit, it should be continued by the patient indefinitely. Even with limited resource, it has been proven the program will give the expected benefit to the patient. So our approach, we have arranged pulmonary rehabilitation to all multiple groups of diseases, COPD, bronchiectasis. So you can see the 6-minute walk test, saturation, all have improved in some patients, but their quality of life has markedly improved. So equipment, we don't want to rely on the hi-fi machines, but sandbags, therabands, dumbbells, staircase, ball, stopwatch, facilities for musics and chairs. That's all we were used. So pre-assessment, exclude contraindication, recent infective exacerbation, ischemic heart disease. Before starting program, we will weight, height, BMI, quality of life questionnaire, then resting saturation. Those are to be clearly documented and then followed up. Duration, we have done 2 days per week for 8 weeks. So our rehabilitation team is like this. So we have taken, we work as a team, the team spirit was there. So everybody wanted to improve the patient's quality of life and all these things. So we had got the sponsorship because we wanted to provide some milk or whatever. Then the patients will attract to the rehabilitation program. So we found some sponsorships as well. So what we did was like this, TheraBands. So you can see that the TheraBands are used by one group of people, sandbags are used by another people, dumbbell are used by some other people. So like that, the resources are very limited, but still we are greatly enhance their quality of life. So my take-home messages are COPD is highly prevalent disease in Sri Lanka as well as worldwide. Health burden is enormous. Identified COPD earlier when intervention to prevent disease progression may be more effective. Multi-system disease. So multidisciplinary approach is evidence-based treatment for COPD. So thank you very much.
Thank you very much, Dr. Samanmali, for that very informative talk on COPD and how to manage. Especially, I feel it seems that you are doing a very good job, especially during these challenging times. So do keep it up. As we are running out of time, we have room for just one question. So the question is, in category D, even if the eosinophil count is high, do you start with LABA/LAMA only, or do you start the ICS as well at the same time?
Yeah, ICS has a very important place in increased when there's a high eosinophil count. Yes, we have to start with ICS as well.
Thank you very much, Dr. Samanmali. Now we're going to move on to the next lecture. The next lecture is by Dr. Vatsala Gunasinghe, who's currently a consultant chest physician at National Hospital of Respiratory Diseases, Balisara. She has a special interest in pulmonary tuberculosis and pleural disease. Dr. Vatsala is going to talk to us about something that's relevant to especially the youngsters in Sri Lanka at the moment, with regarding to smoking, e-cigarettes, vaping in the Sri Lankan context. I'll hand it over to Dr. Vatsala to continue.
Thank you, Riaz. Kind words of introduction. And I would like to thank Sri Lankan College of Physicians also for giving me this opportunity to talk to you today. So today is 31st of May, World No Tobacco Day. So I am talking to you regarding this topic, especially because you are all future leaders of the healthcare in our country. And I hope my lecture will give you some information and make you more knowledgeable, and also make you more motivated toward the reshaping of our future healthcare, especially regarding smoking and related products. So this is my lecture outline. So we'll be talking about tobacco products briefly, smoking harms to the body, harms to the lungs, and also regarding tobacco advertising and marketing strategies versus legislation, and also especially regarding what are the newer challenges. So we'll be talking about the newer challenges. So the first one is also regarding the newer challenges, especially regarding e-cigarettes and all. So what are the tobacco products? There are many products and many harms. So smoking, what are the smoke products? You have the pre-made commercial products, and also where you smoke tobacco leaves in pipes and water pipes. And also tobacco is sniffed and also chewing. So there you can see in the pictures young people using and some of the products that are available worldwide. Yeah, we are discussing regarding the smoking. So what are the harms to the body? And as you know, cigarette has more than 4,000 toxic chemicals in cigarette, and especially we are concerned about nicotine, carbon monoxide, and tar and other carcinogens. And if you look at the overall effect to the health of the body, you can see there are many cancers that can happen, especially lung cancers, esophageal cancers, and related to oral cavity cancers, laryngeal cancers, pancreatic cancers, and bladder cancers, and also cardiovascular diseases. And especially in the respiratory context, COPD and chronic bronchitis. And also it will increase the risk of infections as well. What are the harms to the lungs? Cigarette smoking has clear epidemiological association with lung disease. And we know that there are more than 4,000 chemicals that will target the airways, and they have marked irritant properties. And there are over 60 known suspected carcinogens. And also importantly, there's oxidative stress that will affect the lungs as well as the rest of the body. And the cigarette smoke will affect the bronchoalveolar and interstitial compartments involved as well. Then briefly looking specifically regarding the lung, as you are aware, we have COPD, lung cancer. Those are the ones that we are well aware. But apart from that, there are a whole bunch of smoking-related interstitial lung diseases. We had a lecture on interstitial lung diseases earlier. So there are specific category related to smoking. So they are called SRILDs. So especially RBILD, DIP, PLCH is the lung cancer histiocytosis. So those are related to smoking. And there's this interesting entity called combined pulmonary fibrosis and emphysema as well. And also idiopathic spontaneous pneumothoraces are associated with smoking. And other conditions are like acute eosinophilic pneumonias, pulmonary hemorrhages in good pastures, and also TB and other related infections. So those are related to the lungs. So if you look at the how commonly they are associated, or what are the causal relationship that or the association, you can see like 100% of the cases of CPFP or combined pulmonary fibrosis and emphysema smokers, and also RBILD or respiratory bronchiolitis ILDs are also smokers. But don't forget, this is not only if you are a smoker, it can happen in second-hand smoking also. All these diseases can occur because somebody else smokes in your household or in the office or where you live. So you have to keep that in mind also. Next slide, please. So we know all about the harms. So despite all the harms, why do we still use tobacco? So you can see the effectiveness of the advertising. These are from the past, but you can see where they have focused on the adult males and also females, younger generation. So there had been a marketing and ongoing marketing as well, but not direct as this, but that has been a huge thing that made people use tobacco. And then when you start using it, nicotine is, is addictive. Then they will continue to use it. So that is how this is maintained. Next slide, please. So we'll briefly look at the tobacco smoking history and legislation. It was introduced because if you understand the history, you can understand the future also, hopefully. So it was known about 6,000 BC, then 1492, it was like around that time, it was detected by Westerners and then brought into the rest of the world. Then people industry actually gave for the soldiers free of charge, and there were a lot of young addicts, and also there were marketing for women, and then so that tripled the sales. And also later on we got to know regarding the side effects, but it took long time for the legislations to appear. So what are the legislations? One thing, taxation, of course, they have started early, but control measures. So they are legally obliged to put a warning, and also banning or they have to print a warning, and also there's banning on advertising on the television and radio, and some nations even internet is banned. And so there some use these graphical images of the side effects of smoking, as we do in our country. And also most of the countries have a ban on public smoking. Next, and also there are restrictions of the age where you can sell smoking too in most of the countries. And also some countries have point of sale advertising ban. So if you look at the, whether this is really a success story. So tobacco advertising and marketing strategies versus legislation. It's actually a partial success because most of the countries, it has reached a plateau level, or at least it's not increasing the tobacco use, these restrictions and taxation, but this is not really reached the rest of the developing world, and also female and youths, this tattooing is not that significant. Still, at this stage, it is killing more than 8 million people a year. So in this context, what are the new challenges? We have this novel and emerging nicotine and tobacco products. So those are the new challenges. So we look at those. One thing is what we call as a heated tobacco product. That means it's not a, we have to burn a cigarette. No, so this is a not burning. Without burning, they heat, and whatever the chemicals in the tobacco is released. Then the other product is e-cigarettes, which I am going to talk to you in detail. So these two products are the novel ones. They are more attractive, and so there are problems. HTP is all heated tobacco products. Nalina, can you go back? Remain there, yeah. So HTP or heated tobacco products are like all other tobacco products. They are not different from cigarettes. All the side effects and all those things are there. One only thing is that they are called smokeless. They don't have a smoke tobacco. So the CDC warning is that is Center for Disease Control and Prevention in US. They have the same warning for heated tobacco products as similar to cigarette smoke. Then the e-cigarettes, that is the special one we'll discuss. Next slide. So e-cigarettes is known in many like words. You call it a vape, vaping, e-hookahs, then vape, pens, and all those things. So there are two types. Actually, the main one is the electronic nicotine delivery system, so ENDS, and also where they have this device that have nicotine and other products we'll discuss, and there are certain devices without nicotine but with the other additives, additive drugs. So we'll briefly go to e-cigarettes. Electronic cigarettes or e-cigarettes are battery operated devices that heat a liquid usually containing nicotine, producing an aerosol that user inhales. And initially it was entered the market as consumer products without government regulation. And initially it was produced as small quantities by small companies, but later on they had been bought by major tobacco companies. So you can see where that is leading. So this is the structure. You can see the battery and the atomizer and the cartridge containing the fluid, vape fluid, and when it is heated, the vapor will be inhaled. Yeah, so in this, so we call this fluid, sometimes it's called vape juice or e-juice. The liquid is heated to produce an aerosol the user inhales. So nicotine, e-cigarettes have nicotine. The ones without nicotine does not contain nicotine. In addition to nicotine, they are generally having propylene glycol, glycerol, and or flavorings. Those are there to make them more attractive. And also they are known to have a lot of other chemicals, sometimes unknown also. So there had been these things, tin, lead, nickel, chromium, even arsenic had been found in e-cigarettes. So it's not a simple device. Next slide, please. So there are several generations of e-cigarettes. First generation e-cigarettes make the shape and size of a conventional cigarette. And second generations are more like pen style or tang style. And third generation has more room for customer modifications. And the fourth generation products, what we call as pod mode devices. This is the one you can see a lot of them increasing in popularity among adolescents. And this popular brand is also there. They are small in size and discreet in appearance, and it is sometimes you can take it unnoticed to schools. So they can deliver higher concentration of nicotine without throat irritation, this brand product. So this is the one that is causing problems, like the usage increase with this kind of attractive products. And there are other novel devices also which are similar to, like, look like a cigarette, but small and brightly colored, and also with many flavors like fruit candy, mint. So you can imagine how attractive it is. Then what are the concerns and harms regarding e-cigarettes? So use of e-cigarettes have increased over the past decades, and more significantly increased among middle and high school students. This is US data. And because I think you can see the graph, 2019, 2020, there had been peak, and probably because of COVID and the school has been closed, it has been coming down. So the potential adverse effects can be related to exposure to nicotine, as well as the other aerosol components that are there in these cigarettes, as well as the actual device. Okay, we'll look at them. Next slide, please. This is what the CDC says. E-cigarettes have potential to benefit adult smokers who are not pregnant. So that is the only context that the CDC advises the use of e-cigarettes for adult smokers who want to quit, and they should be non-pregnant also. But they are not safe for youth, young adults, pregnant women, as well as adults who do not currently use the tobacco products. So there are more research needed, and they advise not to start if you have never used any tobacco products. Next slide, please. So risk due to the constituents, as we said, nicotine exposure poses a certain risk, but long-term studies are needed. But generally, they perceive nicotine exposure per se is not going to give a lot of long-term side effects, because there are people who have been using nicotine patches and all those things long-term. And then aerosol also, vapor exposure, most that is another, that is the one that is more concerning, because there are a number of potentially toxic chemical substances other than nicotine. And also the other issue is sometimes the people might refill the empty cigarettes cartridges with various substances and carriers that may increase the risk of harm when heated for inhalation. Like they might refill. So in this context come the condition called e-value, e-cigarette or vaping products use associated lung injury. So what is this? Yeah, this is e-cigarette or vaping product use associated lung injury, originally called vaping associated pulmonary injury. Initially described in 2019, it's an acute onset or subacute respiratory illness that can be severe or life-threatening. There are more than 2,800 cases reported in the CDC by 2020, and there had been 68 deaths. So it's not a thing that is lightweight. So there are some association. Some people have only used the nicotine containing one. Some have had this tetrahydrocannabinol containing e-cigarettes. And some are related to the informal or illicit sources of e-cigarettes, and some causal relationship in associated with vitamin E contamination. So these things are not proven to be associated with these cases. So this is what you see in the X-rays and the CTs, and this is like a acute respiratory distress syndrome. So in this case presentation, I will not go into detail, but you can see it's only a 22-year-old patient who has come with fever, vomiting, cough, white sputum, and a history of THC vapor use, and he has been quite ill, and all the other investigations had been negative, and they have done a bronchoscopy and bronchial lavage, and ultimately they needed ventilation also, and they have treated with steroids. So that is the case. So there are many cases, similar cases reported. So there are certain criteria, also proposed criteria for this diagnosis. And this can be different ways, like it can be a acute diffuse alveolar damage type, alveolar hemorrhages type, lymphoid pneumonia types, and there are also the hypersensitive pneumonitis type. So there are different ways that this EVALI can happen, like the pathology. So when you compare the fatal and non-fatal cases of EVALI, the fatal cases are more over the people who are 35 years, and by the mean age, 35 years. And medical history, usually they had some comorbidities like asthma, cardiac disease, or mental health, and obesity. So it's more or less similar to COVID, isn't it? So there are, if the comorbidities are there, they tend to have the worst prognosis. So what is the optimal treatment of this condition? It's unknown, and you have to treat it as a community acquired pneumonia and screen for the possible etiologies, and steroid therapy and supportive care. Those are the ones that are established. So what are the other concerns? So as I said earlier, because this is a recent, like newly upcoming thing. So consequences of chronic e-cigarette aerosol inhalation is largely unknown, and the levels of toxic and carcinogenic components may also vary depending on the e-cigarettes and also the device. We don't know the safety of carcinogenic effects of propylene glycol when they are heated. And also long-term cardiovascular risk, we don't know. And also nicotine containing, and nicotine can cause some short-term increase in blood pressure. And there are no data on the long-term risk of cancer. So that is how we stand for that. And also there are certain risks associated with the devices, because these are battery operated ones. They have caused injuries like explosive injuries and chemical injuries. So those are also concerns. What are the other concerns? If you look at the from the public health aspect, there are major concerns. One is we might create a population who are nicotine dependent. Other one is that we are normalizing the smoking behavior, that we know it is not culturally accepted to smoke in most of the in our country or the Southeast Asia. So we have reached that level, but this reintroduction or introduction of e-cigarettes might make it normalized. So these concerns are there. So this is, I have quoted the reference also, because there's ample evidence that e-cigarettes have been marketed using many of the strategies previously used by tobacco companies to market the conventional cigarettes to youth. So that is a statement, and that is so that is something that is concerning the healthcare workers like us. So we look at the Sri Lankan context briefly. Generally, we have been going down, smoking, we are going downward trend, and still there are some certain significant deaths amount, but we have very low women smoking, and male smoking also has been reducing. So we have very good tobacco control policies, like we have the tobacco advertising. We know we have 80% pictorial warning in the cigarette packets, and tobacco is banned public spaces, and we prohibited to sell to young children less than 21. So those are in place. So they can't sell it around the schools and educational facilities as well. But regarding the sales of e-cigarettes, the law bans the manufacture, import, sale, and offer the sale of e-cigarettes that contain tobacco. Despite the fact that law includes the phrase that contain tobacco, this provision is being applied to manufacture, import, sale, or offer for sale of all e-cigarettes. That's what the analysis says. So some of the components are allowed, like advertising is allowed, point of sale product display not applicable. So a lot of things are not applicable. So this is a little bit of a gray area regarding e-cigarette legislation in Sri Lanka. Because I was researching through this topic and I looked in the internet, and especially this initially happened because there's a public concern, like media concern regarding vaping in Sri Lanka. So we went back and did some research. So these are like some screenshots I have taken when I am searching. So it's available. When I search back in the history, I have seen some TripAdvisor and all, where the tourists say that about 6 years ago, none of these products are available, like to refill and those things are not available. So you have to bring all those when you are coming from your country. That is what they have suggested initially. But now it is available, becoming available. You can see that I have not personally called and checked whether these are actually these, but in the internet, they appear as these are the places where you can obtain e-cigarettes and vape. So, and there's a public concern, especially I think in this context where the children are more in the internet, online, and these things also, these addictions also might come. So what is the way forward? Regarding tobacco smoking, we need continued monitoring and strict implementation of legislation regarding tobacco products, marketing and use. And also we need continued public awareness on harms of tobacco. And we need to establish a formal smoking cessation programs throughout the country with the necessary manpower, nicotine replacement therapy, and other things. Okay, and that is where we stand for tobacco smoking. We are fairly good, but we have to improve. Then e-cigarettes, as I said, we have to do review and research on current Sri Lankan market, and also clear the legislation on availability and outside of formal smoking cessation programs. And also we have to be mindful regarding the legislation on marketing and availability for youth and novice. Also, there might be a place for public and especially parent awareness. Briefly about smoking cessation, because I have added this just for the completeness. As we all know, we have to always ask the patient whether you smoke, and if they say yes, you can follow these like 5 A's algorithm or 3-step AAR algorithm. But generally, the thing you must do is you can ask, and you have to advise them to quit smoking, because it is proven even brief advice to quit has been shown to increase quit rates. And practically we have seen that when we firmly say you can't smoke no longer because you're having this lung disease, asthma, they will stop then, and they are most of our patients. So you can to do that. And individually, if somebody is willing to quit and having difficulty quitting at one go, then we can refer them to behavioral support and pharmacological treatment. We have drugs. I cross-checked with the psychiatrist today also. So we have these drugs that are clean, and also bupropion. We can those drugs are available, but out of stock time to time. But those are available with them. So if we refer to them, they can prescribe these. And nicotine patches also some time to time is available. And also we know in the market there's nicotine lozenges available, no smoke. So these are available options for our patients. The only thing is you have to be concerned enough to ask and also refer. And also the one other thing I want to highlight is when you meet somebody who smokes, you have to always advise regarding the risk of second-hand smoke exposure. You have to tell them you are making your household members, especially children, they are at risk. So you should not smoke indoors. So that is one major advice you can give, like one important advice. So those are that is only briefly, because this is topic itself. These are my references. So thank you. That's the end of my presentation. I'm happy to answer any questions. So I think there's one question regarding regarding the methods. Do they available in the? I don't know which one they are referring to, whether e-cigarettes or the smoking cessation. Both are yes, and of course I explained regarding those. And Risk of passive smoking, of course, I am not 100% how should you assess, but always you have to advise not to smoke indoors. There's definitely proven research proven risks are there. Okay, thank you very much for your patience.
Thank you, Dr. Asla. Thank you very much for that very informative lecture. I think that was very helpful for everybody. Next, I'd like to introduce our next speaker, Dr. Tanuja. She's a consultant respiratory physician of National Hospital of Respiratory Diseases, Varisara. A special interest in lung cancer. I'll hand it over to you, Dr. Tanuja.
Good afternoon. First of all, I would like to thank Ceylon College of Physicians and College of Pharmacologists for giving this opportunity to talk today. And next 20 minutes, I will be talking on pleural infections, which is a very common and fatal disease. This is the outline of my talk today. So pleural infections, this is a very old disease, and earliest report of empyema is credited to the Egyptian physicians in 3000 BC. In 500 BC, Hippocrates gave a clear description of the disease, including open thoracic drainage, closed chest tube drainage, first illustrated in 1873. And after 2 years, German internist described how he treated empyema by puncturing the pleural membrane with a trocar, introduced a rubber catheter into the pleural cavity, then attached the free end of the catheter to a bottle 1/3 full of solution, allowing pus to flow freely from the pleural space into the bottle. And now we have well-developed closed pleural drainage system. However, despite this, pleural infection continues to remain as a life-threatening disease, and 20% require surgery, and in 1 in 5 die within the first year of diagnosis, and this is more in frail and elderly. 15% presenting to medical care requires organ support. When we talk about pleural infections, we are mainly dealing with parapneumonic effusions and empyema. Parapneumonic effusions can be simple or complicated. In simple parapneumonic effusion, the fluid is uninfected and it's free flowing. In complicated parapneumonic effusion, the fluid is infected with microorganisms. Empyema is the frank pus in the pleural space. When the effusion is complicated with internal occlusions and multiple septae, we call the effusion is complex. 20 to 50% of patients with community-acquired pneumonia have evidence of parapneumonic effusion. Older age, multimorbidity, and immunosuppressive states are the main risk factors. Next slide. Pathophysiology. So normal pleural space can accommodate up to 10 to 20 ml of pleural fluid, and this is kept in a balance with formation and resorption, and effusion result when this balance is disturbed. Next slide. Infected pleural effusions can go into 3 stages. Stage 1 is the early stage, and fluid is free flowing, and it's exudative and neutrophilic, and the pH and glucose is also normal, and no evidence to support any infection with microorganism in stage 1. And then the second stage is stage 2 or fibropurulent stage. Complicated parapneumonic effusions and empyema will come under this stage, and there is bacterial invasion across the damaged pleura, and it stimulates inflammatory response, resulting in fibrin deposition and loculation. I think you can see this purple color fibrotic strands with loculated effusions, and if we analyze this fluid, we can see low pH, usually less than 7.2, with low glucose of less than 2.2 and high LDH. But interestingly, fluid characteristics may vary among pockets of fluid. And then the final stage is the chronic organization stage. Pleural fluid begin to organize, and now the fluid is very thick and we can't drain. And then there's a risk of developing trapped lung if we don't treat. And usually stage 3 is beyond the medical management. Microbiology, positive yield of from the pleural fluid is usually 56%. Organisms are different from pneumonia due to the hypoxic nature of the pleural fluid, and it favors growth of anaerobic bacteria. In many cases, it's polymicrobial. Gram-positive cocci are the commonest organism, followed by aerobic gram-negative bacilli and anaerobes. Diagnosis by the combination of clinical picture, imaging, and pleural fluid analysis. Chest X-ray is very helpful as the initial imaging method and typically shows encysted pleural effusion. Next slide. Thoracic ultrasound is very cost effective, it's radiation free and readily available at the bedside, and it can offer real-time guided interventions. And when there is pus within the pleural space, we can detect because there can be highly echogenic fluid particles, and it is also very specific and sensitive in detecting complex effusion. We can detect septation, and in that case, ultrasound is very superior to CT scan. And when there is multiloculated collection, ultrasound helps to identify the largest locule and then guide to insert the tube. So these are images of complex effusion with the ultrasound. You can see multiple septated septae with multiple loculations of fluid pockets. CT chest is to identify complicated parapneumonic effusions, and there are some specific features that are more specific to infection compared to malignancy, like contrast enhancement, air locus, pleural fluid volume of more than 400 ml, split pleural sign, pleural fluid loculation, and features of parenchymal infection absent in about 1/3 of patients. So it's not the pneumonia, it's the cause of, all the time. So this shows split pleural sign. You can see two fluid pockets with separation of the visceral and parietal pleura. The below pockets is a bit large and causing compression of the underlying lung. The next image shows air locus, which indicate gas forming organisms or anaerobes are within the pleural fluid. Pleural fluid analysis is the gold standard, and aspiration of pus confirm the diagnosis and does not need further biochemical analysis. And it's usually exudative and neutrophilic. pH is the most powerful clinical indicator for pleural drain, and the cutoff is less than 7.2. And low glucose of less than 2.2 and LDH of more than 1000 is also supportive. And sometimes we can see organism with Gram state. Next slide. Management. If an empyema does not rupture, death will occur. So despite advanced management options, still this is associated with very high mortality of 20%. And rapid score will help to risk categorization of the patient, and I will talk this in my next slide. And drainage of the infected fluid with timely and appropriate antibiotic therapy is the mainstay of treatment. If the fluid is not responsive to initial drainage, then we can go for either antifibrinolytics therapy or surgery. This is the rapid score. R stands for renal, and we have to check blood urea level. A for age, P for purulence of the fluid, I for infection source. If it is hospital acquired, the score is more, and D for dietary factors, and we have to check albumin. According to this, we can categorize the risk as low, medium, or high risk. So we can early identify high risk patients and start aggressive management. Antibiotics, we have to always treat according to the local guideline policies. Pleural infections differs bacteriologically from pneumonia, so require different treatment. Antibiotics for community acquired infections, we have to cover both aerobic and anaerobic bacteria. If you're treating for hospital acquired, these infections are very resistant. So we need to cover both cover gram negative, Staph aureus, and mixed aerobic infections. And this is associated with high mortality. Yeah, next slide. Pleural drain insertion. If there is empyema or pus, this is an indication to insert urgent drain. Other than that, if the pH is less than 7.2, if there are microorganisms in the gram stain, again, we have to do urgent drain. And so now there are several types of drains available. We can do either traditional intercostal tube, the larger one, or this small drains with Seldinger technique. However, the size will not cause a big problem. And if the clinical response is poor, escalation of care is needed. So now I will talk about intrapleural fibrinolytic therapy. So you can see this image shows septated effusion. If we have a patient with pleural infection who has a simple effusion, we can insert a drain and we can freely drain the fluid. But what will happen if we insert a drain to this patient? So we can do a bedside ultrasound and we can identify the largest locule and can insert a drain, but it will drain the fluid only which is inside that fluid, not the rest. But so then this is not enough. So what we can do, we can refer to surgery, then we can break this septum and remove the infected fluid, or else we can give intrapleural fibrinolytic therapy to break these septae and then these pockets will be interconnected, and then it facilitates the evacuation of fluid. So this therapy is recommended for complicated parapneumonic effusions or empyema who fail antibiotic therapy and initial fluid drainage. And this is best suited to patients with multiloculated effusions in whom septa are suspected to be early. In that case, we can break them easily. However, it is less effective in stage 3, but no data to define a type. So regarding intrapleural fibrinolytic therapy, this was first described in 1949 by Miller et al. Using streptokinase. However, the streptokinase which was used during that time was not purified. Therefore, there were a lot of immunological side effects. In late 80s, purified streptokinase became available, and after that, there were a lot of small studies which shows good clinical outcome. In 2005, the MIST trial, that is multi-center intrapleural sepsis trial, was conducted and evaluated intrapleural administration of streptokinase. However, this trial did not show any mortality benefit, rate of surgery, or the length of hospital stay. This is because we are giving streptokinase, and streptokinase can break down the septate, but it will not reduce the viscosity. So even though if you break the septate, the fluid is still thick. So we need something else to reduce the viscosity. So that's how this DNase came to play. So DNase, data on cystic fibrosis patients, they have found that nebulized DNase reduce the viscosity of secretions and improve airway clearance. Next slide. So MIS2 was initiated after this. And in here, instead of streptokinase, they have used TPA or tissue plasminogen activator with DNase. This was a randomized control trial with 4 arms, recruited 210 patients over 3 years from 11 UK centers. And they compared placebo alone, TPA alone, DNase alone, and the combination TPA plus DNase. Primary outcome was to check the absolute reduction in chest X-ray opacification. Secondary outcomes were duration of hospital stay, referral to surgery, and death. And this study have proved that combined therapy have a statistically significant benefit in all of these measures, and also confirmed neither fibrinolytic or DNase alone were no better than placebo. However, this study is limited because there was only a small number of patients were enrolled. Next slide. So after MIS2, there were more than 100 case series, including more than 600 patients have been published with no safety concern, and also they have used the same regime as the MIS2, and they have also found good clinical outcomes. Main concern is the bleeding. However, it is not significant. Next slide. Currently, we don't have TPA DNase combination here, and this is one of the accepted protocol to use combination treatment. So before starting treatment, we have to exclude any contraindication, and we need to get the consent. And before starting, we need to check baseline vital signs, and during the procedure, so we need to check because they can get hypovolemic shock, and then we can administer TPA and DNase through the test tube. Usually twice daily for 3 days, and after that tube is clamped for a while, and then we have to unclamp to drain the fluid. Then we can check the fluid output and need to look for bleeding, and daily imaging with chest X-rays or ultrasound. Dose de-escalation can be considered, and this treatment is cost-effective compared to surgery. Surgical intervention in final organizing stage, because in this stage, medical management, including intrapleural fibrinolytic therapy, are likely to fail, and 50 to 20% warrant surgical intervention and include both VATS and thoracotomy, and then the surgeons will do decortication and remove the infected fluid. Future direction. So up to now, there are no head-to-head trials which compared surgical treatment and intrapleural fibrinolytic therapy. So MIS3 is ongoing, and they are recruiting the patients with pleural infection and randomized to antibiotics plus early VATS versus standard care or TPA DNase combination, and we are awaiting the results. Finally, I thought of sharing this patient with you. This is a middle-aged patient who was transferred from another hospital to Alisara for further management of empyema. Before transferring, they have done the pleural fluid analysis and they have aspirated pus. However, so you know that if there is pus within the pleural space, this is an indication for urgent pleural drain. But however, unfortunately, this patient was transferred without inserting a drain after diagnosing the empyema, and the delay was like more than 24 hours. And actually, he came to the clinic as a referral. And when he came to us, he was in, in very severe septic shock. And even though we have started strong antibiotics and we drained the fluid, but still we also could not save this patient. So empyema is a condition that you can't wait. So in conclusion, pleural infection is a common disease with significant morbidity and mortality, rising incidence in worldwide despite improvement in healthcare practices. Proper antibiotics and prompt fluid drainage is life-saving. It is a considerable economic burden. Role of medical management is expanding, and it's cost-effective. So that concludes my presentation, and thank you for listening, and happy to answer for any questions. So there's one question: these methods, do they available in Sri Lanka, and how can we advise on patients? We don't have the combination, and I know that in some centers we are using only TPA or streptokinase. There's another question: how long do we need to clamp the tube after inserting fibrinolytic? This is usually 1 hour, and then we have to unclamp to fluid because we need to drain the fluid. And are there any antibiotic choice in empyema? So we have to cover both aerobic and anaerobes. So we can start second or third generation cephalosporin with some anaerobic cover with either metronidazole, and sometimes we can use coamoxiclair, which have good anaerobic cover. And in hospital acquired pneumonia, we have to reverse staph infections as well. Can you comment about the duration of antibiotics in empyema? So we used to give 4 to 6 weeks of antibiotics, and this evidence comes from the treatment of lung abscess. So we have to give at least 4 to 6 weeks of antibiotics.
Okay, in the absence of any further questions, may I thank the College of Pulmonologists and the 4 speakers for conducting this, helping us conduct this program. There have been a few interruptions due to bad weather, but we still managed to get through. My profound thanks to Dr. Ravini and the College of Pulmonologists, as well as Nalina and his IT team, as well as the CCP office staff for putting this together. I'm very grateful. I hope all the trainees will join the quiz program. The pulmonology quiz will be up on site very soon. Have a pleasant afternoon. Thank you very much.